Hi, this is Barry List at Informs, the Institute for Operations Research and the Management Sciences. You're listening to Science That Better, a series of podcasts about ways that analytics and math modeling help people like you and organizations like your own. The Affordable Health Care Act and reforms in the American healthcare system will make for a change in the way that medical services are provided. It will also make a difference in the world of analytics and IT professionals who work in the business of hospitals. In today's segment, we talk to Dr. Don Kleinmuntz of Strata Decision Technology. Dr. Kleinmuntz is a former president of Informs. At the 2013 Informs Analytics Conference in San Antonio, where we are right now, he gave a talk entitled Hospital Business Analytics in an Era of Healthcare Reform. Dr. Kleinmuntz, welcome to the Science of Better.
Thank you, Barry.
I recently set up an appointment with a doctor and received a lengthy paper form in the mail. I was wondering how much of America's healthcare system is still stuck with paper, and where is American healthcare going in reference to the requirements that will be mandated by what many people call Obamacare.
Yeah, it's interesting because the transformation from paper-based to digital healthcare has been going on for quite a while. And in fact, the current mass move to digitizing everything involving one's interactions with the healthcare system actually started before Obamacare, before the health reform legislation. It actually came out of stimulus packages that were passed in the height of in the aftermath of the recession back in 08 and 09. Mm-hmm. And essentially, it's the hospitals and doctors' offices are making a massive move into healthcare IT, partly driven by stimulus money, partly driven by government regulations and requirements. But they have recognized that now is the right time to get into digitizing your records within their organization, providing more opportunities for you to interact online through websites. And so at some point in the not too distant future, healthcare organizations hope that rather than sending you a paper form, they'll be able to send you a link to a website and you'll be able to put your information in there. And the nice thing about that is that will start to give you as a patient access to your own health information. So already...
So you'll be able to track records.
Track records. Already I can get online at my physician's office in Chicago and I can pull down my lab results sometimes before my doctor even sees them. Mm-hmm. I can print it up and take it, so if I see a specialist in another organization, I can take the results with me to that other organization so the tests don't have to be repeated. So just from an end user, from a consumer point of view, there's a lot of convenience, a lot of benefits to this. From the hospital's point of view, it's huge. It's just being able to have much more information readily accessible, being able to analyze information that was really difficult and expensive to analyze before. Because instead of all the records of patients' interactions with the system being in paper files or on 8 different digital systems, the hope is that we will all move to something that looks like a data warehouse where there's going to be a single one-stop shop for all the relevant information about each patient's interactions with the healthcare system, whether it's the clinical information about what your condition was, how you were treated, what your test results look like, and so on, or whether it's the financial information relating to billing and payments and your insurance company's interactions with the hospital and so on. So this is not new to other industries, but for healthcare, this is going to open up a tremendous opportunity to really get control of the information that's out there.
Now, one other aspect of the Affordable Health Care Act is many more people will be accessing healthcare services. Volume will go up in hospitals. What does this mean, let's start in general terms, for hospitals and the IT and analytics side that you're involved
Sure.
with?
First off, let me say, and this is not an IT issue as much as just basic economics, and let me say from a social policy point of view, if you like Obamacare, if you don't like Obamacare, if you think it's the right way to solve the problem or not, you have to agree that there is a problem in this country. If you benchmark us against other countries in the US, there are a tremendous number of people that don't have the means or the capability of going to healthcare providers and getting care. And it's because they can't pay for it. They either have to pay for it out of pocket, which is tremendously expensive, or they have to see if they qualify for government aid based on income status or other considerations like that. And frankly, there's just way too many people in this society that don't have a means of paying for care, and that's a social policy issue. Now, how you solve it is where a lot of the controversy and the discussion comes in, but the idea behind Obamacare, whether you agree or disagree with the methods, the idea that we would now pay for care, provide people a means of paying for care. So if you don't qualify for government insurance, and one of the aspects of Obamacare is widening the eligibility requirements so more people qualify, say, for the Medicaid program. Another aspect, though, is to create health insurance exchanges so that people who previously didn't have insurance, either because they were unemployed or because their employer was a small company or a small business that didn't have, or they're in business on their own, they don't have the means, they don't have the access to employer-paid health care, which is the way the majority of us get health care in this country, would have access, would be able to go to an online exchange run by either the state or federal government, that they would be able to purchase affordable care. Now, how affordable, what is offered in that care is still being worked out. But the idea is, from the hospital's point of view, that there's going to be a tremendous number of people who are now going to be able to show up in the hospital with a card, or in the doctor's office with a card to pay, that will, get payment for care to the doctor or to the hospital, that weren't able to do that before. And so what's going to happen? They're going to go to the doctor more often. And that's a good thing, because right now anybody in the U.S. can walk into an emergency room and be treated, independent of whether they have capability to pay for care. But often, if it comes to the emergency room, you miss opportunities, because it would have been cheaper, more efficient, more effective to take care of them in a doctor's office a year earlier.
Right. If you had caught a condition before it became critical, you would have spent less, and the setting is an expensive setting.
So it's a win-win for society, for us, for the hospitals. If you know how much the hospital, and now if you're a hospital, the big issue is we don't know how much hospitals are going to be paid for that care, and that's still being worked out. And so that's a big uncertainty that they're struggling with right now. They know they're going to have more demand. They don't know how much revenue is going to come with that demand.
So we don't know how tight the profit margin will be from the business perspective.
That's correct.
And I was very moved by an article in the New Yorker about a year ago which contrasted two different ways of providing health care. One, an HMO here in Texas, another, the Mayo Clinic. One, I guess, was based on cost for services. The other was based on outputs. And do you see this happening under affordable health care, transitioning from one to the other as part of the mandate?
Oh, very much so. There's a complete switch in the business model for health care from the old model, which was called fee-for-service. And quite simply what it meant was hospitals and doctors got paid based on what work they did on a patient. So you do more work, you get paid more. And that's not to say doctors would necessarily, at least most ethical doctors, and that's most healthcare providers, are ethical or try to be. It's not that they do extra work, but the incentives are such that if a hospital wants to succeed, they want to get a lot of patients in and generate a lot of revenue by providing a lot of care to as many patients as possible. That's not entirely a bad thing, but if you create incentives, and this is where fee for value, the new model, comes in, you want to create incentives, if you're thinking about this either from the insurance company's point of view or from the government's point of view societally, you want to create incentives not just to control the cost of care, but also to provide high quality care. And so the new model is moving from simply rewarding volume, the amount of care provided, to awarding quality of care, outcomes, making sure that one is paid for making patients healthier, helping them to live longer. And that's sort of a core issue.
An interesting thing is that you can measure quality of life, and we may talk about that a little bit later.
You can. It is a tricky issue, and that's something that we're all struggling with. The healthcare organizations, the insurance companies, government agencies, everybody is trying to figure out what's the best way to measure quality, but there are metrics out there. And the old saying that is core to analytics is you can't manage it if you don't measure it. And so now they're measuring it, and there's skin in the game. There's dollars attached to it. I think most healthcare providers, and most healthcare providers in the U.S. are affiliated with not-for-profit hospitals and healthcare systems. I think most healthcare providers care deeply about the quality of care they provide. I mean, they're in it, they're idealistic, they're in it to make people healthier. That's why they chose medicine. But having said that, you do have to pay attention to the business side of the equation as well.
And there's also the IT side, and there are going to be special challenges both in IT and analytics. And I noticed that in your presentation you use an interesting acronym called DRIP. What's DRIP?
It's what happens, and you know, so many of our listeners will be familiar with this idea. It's what happens when you encounter big data. You become data rich and information poor. DRIP, D-R-I-P. And so what's happening is hospitals are relatively late to the game if I compare it to a lot of other industries. So here at the analytics conference, you hear presentations, excellent presentations from very large corporate players, with folks in the transportation and logistics space, or in manufacturing, or in retail, where they've been working on their supply chains and improving analytics in their organizations for decades, in some cases. And in healthcare, they're new to the game. In many cases, they're putting in, or they put in their first enterprise resource planning system, ERP system, within the last decade. And right now, they're putting in electronic health records, which is a pretty core system in their organization, for the first time.
And what additional investments are they going to need to make to be solid with the mandate?
First off, meeting those mandates and getting those systems in place is tremendously expensive. So I've heard CFOs of major health systems quote billion-dollar price tags for what it costs between what they have to give the IT vendors and what they have to do to upgrade their IT infrastructure, and then just the organizational and process change, because you're fundamentally changing the way work is done in the organization when you put in a core IT system. So think about your doctor now, instead of scribbling notes, has to be sitting at a terminal. So you have to make sure they're trained in the software. Sometimes that's not easy software to use. And so I've been, just by coincidence, in a doctor's office within a hospital system on the day they went live on their electronic health record. And let's just say things were a little chaotic. And you had nurses and doctors and clerks all waiting in line at the help station, waiting for somebody to come help show them how to do things that the day before were just routine operations. And so there's a learning curve. There's a lot of time and money. These are massive projects, and even if they go well, they turn out to be very, very expensive. If they get off track, forget about it. That's, you know, the direct investment is important. Where we haven't really had enough experience at, and where everybody is hoping, but very few people have proved out the benefit, is on the ROI side, the return on that investment from all of this IT. Because the vision, and it's hard to argue with this vision, is that we'll be able to build out enterprise data warehouses that have all the relevant information, clinical, financial, operational, about patients' interactions with the system, about what services are provided, how they're provided, how much it costs, what supplies get used, and so on. Wrap all of that together and be able to analyze it and get much better insight into the true cost of delivering care.
Now, we've been talking a great deal in the analytics movement about three types of analytics: descriptive, predictive, and prescriptive.
Absolutely.
And you've been in this sector since 1996. Based on your experience with descriptive analytics, let's focus on that for a moment, where do hospitals need to go in terms of their reporting systems?
A lot of it is building out more sophisticated, more flexible, more modern reporting systems. So a surprising number of organizations are running their reports through old mainframe software or home-brewed systems they built a decade or more ago. And the problem is there might be a few analysts down in the basement who are the experts and the whizzes at handling that. But if you're a service line manager or a physician administrator in the hospital and you get a report, first off, do you even look at it? Second, do you actually understand it, and what do you do about it? So you see something where you're compared to targets or benchmarks on critical quality indicators. or on key performance metrics coming related to cost or efficiency. Those are all very important. You know they're important. But now, what's the action implications for the organization? What's causing something to be off track or not where you want it to be? And we need to make it self-serve so that the end user can drill down into the data and do simple analyses, simple drill down and looking at underlying details to be able to get some insight into what's going on. And if there's a problem, just identifying the fact there's a problem isn't good enough. You also have to give some ability to understand, diagnose, and then act on the problem. And so we need to make systems that are much more flexible from that point of view. We will still need skilled analysts to produce reports that are as compelling, as visual as possible, but also a lot more emphasis on interactive reporting, data mining in the small d sense, not big sophisticated data mining like we see in some settings, but just exploring data, understanding what you're dealing with in your own part of the organization so you can manage it better.
And I thought that in your presentation you boiled it down to 4 words of wisdom,
Sure.
so to speak. You talked about descriptive analytics having to be fast, number 1, compelling, number 2, self-service, number 3, and number 4, turn a tracking system into a learning system.
Yeah, and I already talked about self-service. The fast and compelling, an important aspect of that is all too often when you're running on these old legacy systems, you may not have all the data you need for the reports you really want to run. So it's not just about cost or about quality, but it's about wrapping the two together in the same system so you can look at the trade-offs between cost and quality. For instance, are you really getting, if you're paying more for cost, are you getting more quality? Are you getting better outcomes or not? And understanding that. But also in terms of fast and compelling, it would be really nice if your daily productivity reports or your weekly financial performance reports didn't take days to turn around and come back. And so being able to get results quickly, fast, self-service feeds into that in terms of not having to wait for an overworked analyst to turn a request around, but also just making the routine processes around reporting smooth, easy, tied into your email systems and other sort of modern means of interaction and communication. And then the other piece of this is it's the fast, compelling, self-service, and then the fourth
turning
one.
the tracking system into a learning system, which is
the learning system, and that's really about giving people, creating accountability. So saying, here's a gap in performance, we'll give you the tools to figure out what's causing it. Now tell us what you're going to do to fix it, or if there's anything you can do to fix it. Tell us why it happened, tell us what you're going to do about it, and then we're going to come back next month or next week, whenever the appropriate time is, and have a conversation about whether you're getting the results you expected and why or why not. So that kind of accountability keeps everybody focused, everybody on track. And so the learning part of it is to get people more skilled, more understanding of where the organization is going, and start to build more continuous performance improvement into the core of how the organization manages itself.
Now, moving up the food chain in terms of analytics, those in the field think of predictive analytics as a level higher. Mm-hmm. And what is it that people in healthcare will want to predict in terms of the business of hospitals?
First off, I think it's really important to note that if you think about, as a lot of people talk about analytics maturity levels, healthcare has recognized the need for predictive analytics, but hasn't done anywhere close to enough of it yet. Ironically, I work primarily with the CFO, with the finance wing of hospitals, and they're probably further along in certain respects with respect to predictive analytics, because they've been producing financial forecasts, trying to figure out where they're going to end up at the end of the year, or looking out 5 to 10 years at where the organization's momentum is heading financially.
This is what people in accounting and budgeting do.
Sure, it's a classic tool in corporate finance is to almost routinely do forecasting. They work closely with people in the strategic planning function in healthcare, and strategic planning in healthcare is really a term of art that encompasses what I think in a lot of other organizations you would think of also as market planning So volume forecasting, how many people, what's happening to the demographics in your service area, how many people are going to demand different kinds of care, is the population getting older, are people having more babies, are there certain categories of health problems that are likely to lead people to seek out care more often in this population, or new trends that are emerging there.
So these are the kinds of things that you'd like to be able to predict over, let's say, 5 years.
Yeah, and there's already work going on in the hospital in this space. I think that they are trying to continually get more sophisticated, more capable in this area. They're trying to bring more data to bear. So one of the things about the drip problem is healthcare used to have a data problem. They didn't have data. Now they're going to, they think, have a data problem, that they will have data, but it'll be the big data problem of
the huge amounts of data
just being
and
swamped.
how do you learn something from it.
Now the question is, what can we do with that data to do a better job looking ahead? Now there are certain problems where the data is going to be tremendously valuable and where predictive analytics is going to add a lot of value. So if I want to know, for instance, how many people are going to show up in my emergency room next Saturday, I really want the time series showing me daily patterns, seasonal patterns. I want to model that using all the stuff I learned back when I took time series forecasting in school. I want a really good modeler to help me, or a good statistician or forecasting person to help me understand, are there new trends emerging, or new patterns, new data patterns that I might want to capture. So even some of the data mining work that's being done in a lot of places might be helpful. Is there
How about risk analysis?
Risk analysis is really important. I've learned this in working with hospital finance, that with so much uncertainty in the organization, you really need to explicitly model not just where do we think we're going to end up, but where could we end up? What are the scenarios that could happen? Do the what ifs, the sophisticated sensitivity analysis on which uncertainties are going to drive my results the most, because those are the ones you want to pay some attention to, as well as understanding from the point of using tools like Monte Carlo simulation to really understand not just what the most likely outcome is, but what the probable outcomes are, and what the range could be, because it's
so you're prepared for that.
So you're prepared, exactly. So the logic of risk analysis, risk management is directly relevant. The other thing that's really important in the context of predictive analytics is not to over-rely on data. And the example I like to cite here is a situation like looking ahead to healthcare after the Reform Act takes effect. And in fact, there's going to be a real shift starting on January 1, 2014, because a lot of the provisions of Obamacare really hit in 2014. So although the data that I have about the operations and the strategies and the performance of my healthcare organization up to this day aren't irrelevant to what's going to happen after 2014, I also have to recognize the limits of that data, because there's going to be fundamental changes in my business model, in my business environment, that aren't captured in historic data. How am I going to deal with that? I need judgment. Preferably expert judgment, but it's got to be some level of subjective judgment.
That's always a problem with time series, when you know that, or you don't know that an event will happen that didn't happen.
And what I would say is, the way I like to think about it is, we need to blend data with judgment in thinking about predictive analytics. We need techniques and tools, and they're out there, but we have to evolve our thinking about forecasting, about prediction, to incorporate, particularly as we look further out into an organization's future, to incorporate judgment as well as data. So start with the data, but also make sure that you're applying knowledge that isn't captured in your databases and insights that aren't captured in your databases.
Now, we were talking about the different levels of analytics, and what people in the field consider to be the highest is prescriptive, being able to give important recommendations. And there's one subject which most lay people think of as intensely boring, which is budgeting or capital budgeting. But people in businesses and corporations know that all the power is in the dollars. So why is capital budgeting hard to do, and what can analytics experts offer?
That's a great question. Resource allocation is not unique to the healthcare organization? And the short answer is many organizations, and I've worked in R&D settings in manufacturing firms, I've worked in the government sector on resource allocation problems, and I've worked with healthcare organizations. And the commonality is they often have more, I've even done this with Informs, organizations have more good ideas than they have financial capacity to fund those ideas. And so now one has to prioritize. One has to identify what what are the benefits of these projects and how do they support the organization's objectives, and let's allocate resources in such a way that we're doing the best possible job in supporting the full range of objectives. Now, in a healthcare setting, it's really important to think about the fact that the fundamental objectives of the organization are their mission. And their mission almost always centers on the quality of the care they're going to produce. Are they going to make people healthier? Are they going to improve the quality of their life? And the number of people they can take care of. So this actually runs back to the issue we talked about earlier behind healthcare reform. More access and more quality as being core issues. But the dollars aren't irrelevant. So you still have to think about and do the kind of financial calculations that any for-profit corporation does, the return on investment analyses. What am I going to get back? I'm going to put in this much money if I buy new technology, if I build a new building, if I acquire a new physician practice. I'm going to have to spend a certain amount of money, and then I expect to see a return over some period of time. What's that going to be? So do that evaluation, and there's a saying in healthcare, in not-for-profit healthcare in particular, no money, no mission. And the positive version of that is if you produce profits, you can invest that back in mission. So you can afford to provide more care, better care, by being a profitable organization. That's important because you don't want to do things just because they're going to make you a lot of money. You want to do them because they're going to enable you to provide more care, but making money is still a key part of the equation. The issue then is looking across that set of objectives, and there's some other objectives relating to making sure you have the right people in your organization, or making sure you have the right infrastructure, both technology as well as plant, as physical capabilities, the buildings and the bricks and mortar. Looking across that full range, really balancing all of those objectives, thinking about which are most important at this particular point in time for this organization, doing that strategic balancing, but then trying to get as much cumulative benefit as possible for the dollars that are available, which are always going to be limited. I typically see hospitals and healthcare systems with 3 or 4 times the amount requested as they have money available to spend. That becomes a difficult problem organizationally too. There's fighting. You have a lot of people chasing limited money. These are all very committed people who are convinced that their idea is great. So now how do you allocate that in a smart way where everybody buys into it? And so we've actually developed an approach that at its heart is run off of an optimization algorithm. So we use integer programming, okay, a technique that's very near and dear to many people in the Informs world's heart. And we allocate resources to maximize cumulative benefit subject to resource constraints and other constraints. Great approach in theory. In practice, you also have to make it work in the organization. So I like to talk about the art and science of analytics, and the art part is making it work in the organization, which means dealing with information, quality, workflow.
And competing interests.
And competing interests, and the organizational, I hate to use the word politics, but sometimes the shoe fits, organizational politics, so building a more collaborative environment. And so the way in which we implement it focuses a lot on the collaboration, the information share, getting everybody onto the same page so that when the result comes out, that they buy into it. So the optimization becomes a tool that sparks a strategic discussion about what the organization really cares about, how they're going to allocate those resources, how they're going to push the organization forward, and how they're going to balance competing concerns like cutting costs versus maintaining quality.
Now, we only have time for 1 or 2 more questions. We talked about quality before. And in terms of prescriptive analytics, how do you measure quality, especially something like quality of life, which you mentioned is extremely hard to do?
Yeah, and that's a really tough one. I think there is room, and there's certainly a scientific literature to support this, that to get better at measuring quality. Right now, there's sort of a grab bag of very specific metrics, which are all related to quality. So things like infection rates, or a big one now because people are actually going to get paid based on whether they hit targets on their readmission rate. And so it's sort of boomerang patients. If you admit a patient to the hospital, treat them, release them, and then they're back within the next 30 days, that seems like a failure. Now, it turns out that's a very hard problem to understand, let alone to improve your performance on. Sometimes it's because there were issues with quality of the care provided. Sometimes it's just because when people have serious conditions, you can't always treat them effectively the first time. And so trying to sort all of that out and understand it isn't easy, but it's clear that that's an important metric. Now, having said that, if we're looking at a problem more globally, like resource allocation, should I spend money on new medical technology versus hiring more doctors? One of the things that we need to think about, particularly when we look at new technologies, new health interventions, is can we measure in a way that's comparable across all the different decisions we're going to make? There's actually been work done in medical decision making, in health policy analysis and medical economics on a measure called quality assisted life years. In theory, it's a great measure. It measures two fundamental things. One is how much longer a patient will live following an intervention. So you might compare in a clinical trial a control versus an old treatment modality with a new one. If it works, patients will live longer. That's pretty core, pretty easy to measure. The harder part is that a lot of treatments also affect quality of life.
And that's harder to measure.
That's harder.
Length of years versus how comfortable they are, whether they're in pain.
It's inherently more subjective. And so what we have to do is really provide a means to incorporate both in a single metric, a metric called quality adjusted life years, where you weight the length of life by the quality of life. Then, of course, looking at how many patients you're helping. So the number of patients that are impacted is also part of that equation. It's simple math, but it's the measurement that's hard, like a lot of things in analytics.
Right. So finally, then, we've talked about a great deal today. An exciting time for people in healthcare analytics as Obamacare is about to hit an important milestone? Absolutely.
It's exciting and scary, I think, some combination of those two. The way I would describe it is, somebody used this expression in a slightly different context, hug your hospital C-level officers, because they're really at ground zero on this fight. They care. They're trying very hard to improve things for healthcare. We have tools that can help them to achieve their objectives, which fundamentally are our objectives, which is more care and better care.
That's all the time we have today. We've been talking with Dr. Don Kleinmuntz of Strata Decision Technology. Dr. Kleinmuntz, thank you for joining us.
Thank you, Barry.
And thank you for listening to the Science of Better podcast by Informs, the Institute for Operations Research and the Management Sciences. For more about analytics and operations research and this series of podcasts, visit us on the web at www.informs.org. Good day, and remember, keep on crunching those numbers.